As I mentioned, tonight's title is Common Thyroid Problems Seen in the Primary Care Setting, and is presented by Dr. Jolene Lowry. Dr. Lowry obtained her undergrad degree actually in PharmD at Florida A&M University. She attended the College of Medicine at the University of Florida and completed an internal medicine residency at the University of Maryland. She stayed on as faculty there at University of Maryland while working as a staff physician in managed care in the Baltimore, Maryland's VA, and she was there for 3 years. She later moved on to complete an endocrinology fellowship at the University of Pittsburgh. She is board certified in both internal medicine and endocrinology and metabolism. Her clinical interests are diabetes, obesity, and the metabolic syndrome. Tonight's presentation is CE approved through AAFP for 1 credit hour. I wanted to also ask to let you know that questions and answers can be submitted to the presenter throughout the presentation. Please feel free to type them into the Q&A box, which you will find located at the bottom left-hand corner of your screen, and click submit. And Dr. Lara will get them as she goes along. In addition, there also will be a question and answer section at the end of the presentation. So with all of that said, ladies and gentlemen, without further ado, let's welcome Dr. Jolene Lowry. Thank you.
Good evening, everyone. Thank you very much for inviting me to this webinar. And let's go ahead and get started. So, of course, again, today I'm going to talk about common thyroid issues seen in the primary care setting. I do not have any disclosures to reveal. The thyroid is such a funny thing, wrapped inside your neck. I'm strong, I'm tough, I'm young and bold, so thyroid, what the heck? It won't stop me from doing well and living life in full. It's such a tiny little thing, who said it had to rule? I don't see why I feel so cold, my fingers hurt like mad. I don't see why I feel fatigued, so why is it so bad? Why is it that I fall asleep every given chance? The muscle cramps, the tired legs, the sickly looking glance. I would get help for all these things, but my memory lets me down. I'm going mad. It's just not fair. I forgot the way to town. My mind's a fuzz, my hair is thin, my nails are breaking fast. The lack of hair around my eyes gives everyone a big laugh. Please, doctor, can you help me? Now I really feel so sad. You can call me in and look away. You think I'm going mad. The tests are taken, all sent off, and now it's time to wait. At last there is a reason, something I can hate. And hate you very much I do for months of grief and strife, for all the days you made me bad to both my kids and wife. You will not win this battle now, all I have the facts. But it's hard to fight this thing and get myself on track. So all of you, both young and old, take heed and listen good. You can't ignore your body's voice even if you could. Oh, so fast things slow down, you can't see what it is. Your thyroid's got you by your throat. Yes, you, not mine, not his. This poem was written by Jack Frost. And of course, this gentleman is talking about hypothyroidism. Poor thing, he sounds like he's pretty sad. And then, of course, we can't talk about the thyroid without talking about how the thyroid has been in the spotlight. And that's, of course, all the celebrities who have claimed that they have some type of thyroid disease. I'm sure you recognize some of these faces. So today I would like to do an overview of thyroid anatomy and discuss thyroid hormone synthesis, as well as discuss hypothyroidism, the diagnosis and management, hyperthyroidism, and thyroiditis. So here we have the anatomy of the thyroid, and as you recognize, the thyroid gland sits underneath the thyroid cartilage. It is the arterial supply is the superior thyroid arteries, and then you have the thyroid veins, which drain the thyroid gland. And here I would just like to quickly show you the thyroid follicular cell unit, which is where the thyroid hormones are produced. So as you can see on the basolateral side of the thyroid cell, you have what is the TSH receptor, and this is where TSH binds to the follicular cell to cause stimulation for the production of the thyroid hormones. You also have the sodium iodine symporter, And then below this you have a potassium-sodium channel. On the apical side of this thyroid follicular cell, you can see that you have the production of the thyroid hormones, and over here is where TPO, which is thyroid peroxidase, helps the iodine attach to the thyroid globulin molecules, and that would be over here. As you can also see, once these thyroid hormones are produced, they are then taken back to the basolateral side of the follicular cell where they actually passively diffuse through the cell and are then allowed to go into the bloodstream. So then, to remind you of the hypothalamic pituitary thyroid axis, remember that TRH is the hormone that comes from the hypothalamus, which then stimulates the production of TSH from the anterior pituitary. And then once this happens, TSH then travels to the thyroid gland itself, and as you saw on the previous slide, it attaches to the receptor on the follicular cell, and this again stimulates the production of T4 and T3. And if you'll remember from those days of anatomy, the thyroid gland puts out more T4 than T3, and in fact later then T4 is peripherally converted to T3 by the deiodination process. So just briefly again, the two thyroid hormones, T4 and T3. So T4 is highly protein bound. The thyroid binding globulin is the most common protein that it's bound to. It is also bound to albumin and transthyretin, which is also known as prealbumin. It has about a 7-day plasma half-life, and previously, most of the time we would check your serum levels of thyroid hormone by checking a total T4. And then if you wanted to kind of get an idea of the binding proteins that were present, you would get the free thyroxine index. Well, this actually has been replaced by the free T4 assay, and now that it's pretty accurate, for the most part, I don't ever check a total T4. I usually check a free T4. Of course, the gold standard still is the equilibrium dialysis test, but of course this is a very expensive test and it's not available in most laboratories. And then of course T3. T3 of course is the more potent of the two hormones, and T3 also is highly protein bound but not as strongly bound to the proteins as T4 is. In a condition like Graves' disease, you actually will see that preferentially the gland puts out more T3 than T4. And as far as hypothyroidism is concerned, we really don't look at T3 for the diagnosis, just because for the most part those levels can remain pretty normal in that condition. And so when you're looking at diagnosing hypothyroidism, which we'll talk about later, you really want to look at the TSH and the T4 levels. And of course the other blood test that we think about, of course, again, is the TSH hormone. And again, it is the hormone that you initially use for screening for thyroid dysfunction. Today the assays are very sensitive, and laboratory testing dictates that it should be, the lower limit of detection for this hormone should be less than 0.02. But of course most of you that have seen the labs know that you can get levels that are even lower than this. So the American Thyroid Association actually has come out with guidelines, and they do recommend that screening for thyroid dysfunction begin at age 35, and that every 5 years after this they continue to have screening if dysfunction was not initially picked up. However, the U.S. Task Force on Preventive Screening actually doesn't have any recommendations, and they don't think that there's sufficient evidence to warrant screening people for thyroid dysfunction. So we're going to transition into talking about hypothyroidism. So of course, hypothyroidism is a condition where there's a deficiency of thyroid hormones. With this condition, of course, that means there is a decrease in metabolism. And if in childhood and infancy if there is a deficiency of thyroid hormones, this can lead to long-term impairment of development. So the prevalence in adults is about 2% for hypothyroidism, and then there's also the condition of subclinical hypothyroidism that we'll talk about, and this incidence is somewhere between 4 and 10% in the population. So there are a number of reasons why someone may have primary hypothyroidism. The number one cause is Hashimoto's disease, which we will talk about later. And then I see more commonly a lot of people who are presenting after they've had therapy for hyperthyroidism, then they become hypothyroid if they've had radioactive iodine therapy. Also, people who have had surgery for their thyroid for whatever reason, and in some cases excessive iodine intake medications like amiodarone, alpha interferon, obviously the anti-thyroid drugs. All of these can cause primary hypothyroidism. There are some people who have inborn errors of metabolism with their thyroid hormone, but this is a very rare condition. So Hashimoto's thyroiditis is a very interesting condition, and I say that because of that poem that I read. But I find that it's just one of those things that you can't always sort out. It's not exactly textbook. So the going theory today is that the body somehow develops these antibodies to the thyroid tissue, and so basically your thyroid gland acts as an antigen, and then you develop these helper T cells that then lead to this inflammatory cascade. So pretty much your body will then develop these antibodies to the thyroid gland. There is this theory that at some point in the past people who developed this condition were at some point exposed to a virus that shared the same protein, and then this led to this cross-reactivity with the thyroid gland. But what happens over time, again, is this inflammatory cascade where you get infiltration of lymphocytes into the gland, and this over time will cause destruction of the thyroid architecture, and this obviously will then lead to hypothyroidism or an underactive thyroid. So in some cases there have been reports of thyroid, what they call hashitoxicosis, so where some people with this autoimmune thyroid disease can actually go through a phase of hyperthyroidism. But more commonly, Hashimoto's thyroiditis does lead to hypothyroidism, and obviously it's more common in women than it is in men. The peak age for this condition is somewhere between 30 to 50 years of age. So the antibodies that are usually present in this condition are called the anti-thyroid peroxidase antibodies and the anti-thyroid globulin antibodies. For the most part, in the early stages of disease, people will have higher levels of the anti-thyroid globulin antibodies, but over time, as the condition becomes more chronic, then you'll see higher levels of the anti-thyroid peroxidase antibodies. So worldwide, Hashimoto's thyroiditis is the most common cause in adults and children of having a goiter and for hypothyroidism. And I don't know if any of you have heard of Smith syndrome before, but Smith syndrome is where you have adrenal insufficiency and primary hypothyroidism together. So in some cases, people will have hypothyroidism as a part of this polyglandular failure syndrome, and there's actually two separate failure syndromes that have been identified. I'm not going to go into detail about that, but in some cases it may also be associated with adrenal insufficiency, as already mentioned, but also pernicious anemia and primary hypoparathyroidism, as well as type 1 diabetes. And obviously with these conditions you have to treat each autoimmune component of the syndrome. Another interesting fact about Hashimoto's thyroiditis is that these people actually are at increased risk for lymphoma of the thyroid. And again, this is a very rare condition, but if you notice that someone's thyroid gland is enlarging and they already have a diagnosis of hypothyroidism or Hashimoto's, then someone that has an enlarging goiter, you need to investigate further, and you would probably go ahead and do a thyroid ultrasound and look for any signs for a thyroid mass In the event that you get concerned that they may have lymphoma, that would require them to have an FNA, or they may even need a core biopsy of their thyroid gland. So this is just a cartoon again depicting what I mentioned earlier. So again, you see at the top of the screen that there is the development of these CD4 T helper cells, which are in response to the thyroid antigen, and then from that point on you will develop B cells that then develop the antibodies to the thyroid gland, and once these B cells then will call for additional help from the lymphocytes, you will get infiltration of the thyroid gland, and this will lead to thyroid cell death and apoptosis. Now, on the other side, you also see the necrosis and apoptosis, and then essentially that will lead to hypothyroidism. So of course there are conditions that can lead to secondary hypothyroidism, and these are, of course, are related to your pituitary gland. So any problem that can lead to pituitary destruction, pituitary adenomas, or if someone has had pituitary therapy, maybe gamma knife therapy or radiation therapy to their brain, could also lead to a destructive process of the pituitary, and that could lead to secondary hypothyroidism. Also, there are conditions of tertiary hypothyroidism, and this obviously would be related to the hypothalamus. So the hypothalamus can no longer produce TRH to stimulate the anterior pituitary. And then there also is a condition called peripheral resistance to the action of thyroid hormone. So this is very similar to insulin resistance, where you have plenty of thyroid hormone around, or you have the thyrotropin or TSHs around, but the cells cannot respond to the TSH, and so therefore it can't produce the thyroid hormones that are necessary in response to TSH. So then there's the condition that I mentioned earlier about subclinical hypothyroidism. So this is the situation where a person will have a high TSH, but the T4 and T3 will be normal. And this definition does not include symptoms or without symptoms, and for the most part we don't really address that. It's basically the biochemical picture of an elevated TSH and a normal T4 and T3. So in this case, there is again, for people who have an autoimmune process, they also may have elevated thyroid antibodies, but it has been shown.
We're going to try to get her back, so hang in there with us, please.
I'm back, sorry. Can you all hear me? Okay, so the controversy again surrounds whether you need to treat this condition or not, because in some cases they feel that people with subclinical hypothyroidism are still at risk for the hyperlipidemia and the other complications of untreated hypothyroidism. So even today still, there's no general consensus on how to approach this condition. In the past, basically there still isn't enough evidence to support treatment of this condition, and so that's why there continues to be controversy. So there are a lot of non-specific symptoms that go along with hypothyroidism, and I find that when patients come to me with normal thyroid levels, but yet they have searched the internet and have looked at every symptom and said, I got this, I got this, I got this, I've got fatigue, I can't lose weight, and I've gained weight over the last few years, and I'm always cold, and my skin is dry, and I'm losing my hair. Losing my hair is always a big problem for women. So they've convinced themselves that they are hypothyroid, but yet their thyroid function tests are normal, and I have to tell them, I'm sorry, if you have normal thyroid function, I can't really say that all your symptoms are related to hypothyroidism. So this is one of the problems that I have to deal with as an endocrinologist, but it could be worse. It could be abdominal pain. So anyway, as you can see, there's a whole bunch of non-specific symptoms that go along with hypothyroidism. And for me, I think the most telling would be the weight gain, the constipation, the bradycardia are some of the convincing symptoms. But the interesting thing is that you have to always think about the thyroid hormone effects on the cardiovascular system. And in severe hypothyroidism, you can see diminished cardiac output, and you can see the bradycardia and the impaired ventricular contraction. And more recently, I had a patient admitted to the hospital with mixed edema coma, which all throughout fellowship I had never seen anyone. And here this woman presented after she basically didn't feel that her thyroid medicine was important enough to take every day, and she did indeed present with respiratory failure and heart failure. And so actual congestive heart failure with hypothyroidism is not common. However, again, in situations where you have very severe hypothyroidism like mixed edema coma, you can see congestive heart failure associated with hypothyroidism. And the other thing is that as far as the increased peripheral resistance is concerned, hypothyroidism itself can then be an underlying cause for chronic hypertension. And so I tell the residents all the time that when they look at the differential of hypertension and they're always wanting to name hyperthyroidism, I'm like, well, actually you need to consider hypothyroidism, because chronic untreated hypothyroidism can lead to hypertension. And then, of course, you never can forget the lipid metabolism changes that happen with hypothyroidism. So you do have an increased total cholesterol, increased LDL, increased apolipoprotein B, as well as little pa. So here is just a chart I borrowed from Dr. Pierce, where she looks at the changes that happen with overt hypothyroidism versus subclinical hypothyroidism. And as you can see, things that are known for sure is that total cholesterol and LDL-C are increased about 30% in hypothyroidism, whereas in subclinical hypothyroidism, they're not really sure. There have been conflicting studies about normal to an increase. The same as HDL, there's a normal to increase with overt hypothyroidism, but no change in subclinical hypothyroidism. And as I already mentioned, the triglycerides and little pa and ApoB are increased, whereas again there hasn't been consistent data about these changes in subclinical hypothyroidism. So obviously when it comes to diagnosis of overt hypothyroidism, again you're looking for a high TSH with a low T4 level. And again, for me, I'm looking at the free T4. So the T3, again, I don't even usually check if I'm suspicious for hypothyroidism. And then in the condition of subclinical hypothyroidism, as I mentioned earlier, you have a high TSH, but your free T4 will be normal. And I have on here T3, but for the most part, that's not really going to help you seal the diagnosis. And then if you're looking at a condition of secondary or pituitary hypothyroidism, this is a case where you actually will have a normal to, you can actually have a normal or elevated TSH, and your T4 will be low. So the treatment for hypothyroidism is levothyroxine, and so you can actually use a weight-based formula to treat patients, and I usually use this if I really feel like their gland has pretty much reached full failure, and so I want to do a full replacement dose, and I'll use 1.6 to 1.7 micrograms per kilogram. In some cases, you can just empirically start with a low dose. You can start at 25 to 50 micrograms and recheck it. But more importantly, in those who have heart disease and are older, you definitely want to start low, go slow. And that hasn't changed for this either. So start low, go slow. And for these people, you want to make very small changes in your dosing increments. So there have been some studies also that have looked at using T4 and T3. T3 is Cytomel on the market. And as far as the benefits of treating clinical hypothyroidism, there are no necessarily any benefits as far as overall clinical picture. There have been some studies that have showed some improvement in mood and neuropsychological function in patients, but for the most part, most people will only use T4 for treating hypothyroidism. I'm sure some of you have probably seen Armour Thyroid and maybe have even had patients present to you that were taking Armour Thyroid that have been prescribed from some other provider. And again, I'm not too far out from my training in endocrinology, and none of the endocrinologists that I train with, and most of them, have been around for a while, use Armour Thyroid. We did have some patients come to our referral center that had been placed on Armour Thyroid from some other providers, and you'll find that these patients are usually very adamant that you can't take them off the Armour Thyroid. It's the only thing that's worked for them. They've tried Synthroid, they've tried Levoxyl, it doesn't work, and that they have to be on Armour Thyroid. And so when it comes to that, if they're very passionate about taking Armour Thyroid, I don't try to convince them otherwise. But if they're seeking a second opinion because things still aren't right, then I try to suggest that they would go ahead and just take Synthroid. And I didn't put this on here, but again, for me, I really don't use anything else but the brand Synthroid. Obviously, I have a lot of patients who are on Medicaid. Medicaid does not pay for the brand Synthroid, and so I tell them that they have to be cautious that if the pharmacy that they're going to changes the generic brand of levothyroxine, they have to be careful, because this can cause a change in the levels of thyroid hormone that they're receiving, because all of the generics are not created equally. And this is why I like to stick to the brand Synthroid, but there's just some circumstances that you can't control for, and that's for people who don't have money to pay for the brand. And as I mentioned before about the hyperlipidemia, you will see that all of those changes will reverse when you start treating someone with a Synthroid for their hypothyroidism. And I just added a picture in here of Synthroid. Nice and colorful. You have all the different doses. The nice thing about Synthroid is that the pills are scored, so if you ever need to make changes in the dose and the patient has pills left over from the last dose, you can always just make a half pill increase in the dose, and this is nice, so to save them a little bit of money. But this also makes it easy for recognizing that if you have a patient and they're like, oh, I'm not sure what dose I'm on, you have it in the records, as they always say, don't you have it in the medical records, but you can ask them what color Synthroid pill they are taking, and that way you can look it up and find out which dose it is. So then back to the issue about treating subclinical hypothyroidism, and actually there are guidelines by the American Association of Clinical Endocrinologists, and they suggest that if you have a person that has subclinical hypothyroidism and they have a goiter or they have positive antibodies, then you should consider treating this person if their TSH is between 5 and 10. However, if their TSH is greater than 10, then you can go ahead and consider treating the person with subclinical hypothyroidism. So, and again, I didn't talk about this, but specifically, if someone's coming to me with subclinical hypothyroidism, I usually go ahead and check antibodies on most people. I just think, again, it's helpful for me to determine, it's not 100% that if they have the antibodies they will develop overt hypothyroidism, but as I mentioned earlier, it definitely increases their risk, and that way I can at least guide them and tell them, right now you're in subclinical stage, but we do need to have close monitoring because at some point you may develop overt hypothyroidism. So essentially, you're usually going to see some improvement in symptoms within about a week of starting the person on Synthroid therapy. Unfortunately, you can't really check labs again for another 6 to 8 weeks because it's the time it takes for steady state and for the T4 levels to equilibrate and then have an effect, feedback effect on the pituitary. So with that being said, you can't check labs for 6 to 8 weeks, but you also shouldn't adjust the dose of the Synthroid for 6 to 8 weeks after therapy is started. Your target TSH goal is somewhere between 0.5 and 3. This is in the normal reference range. And the other thing that you want to be mindful of when you are monitoring patients is also asking them, about taking supplements at the same time they're taking their thyroid dose. They should try to separate these doses for about 2 hours. So between taking a multivitamin and their Synthroid pill, they should separate that by at least 2.5 hours or so. So we'll go ahead and transition into talking about hyperthyroidism. And I'll just take a second and ask if there are any questions at this point about hypothyroidism. Okay, so we'll move on. So, hyperthyroidism affects about 3 million new patients in the United States each year, and I'll tell you, I feel like I probably have seen at least 1 million of these patients. Oh, okay. Oh, so the question from Mr. Adams is, do you think all brand drugs should be preferred over generics, or only in the case of exogenous T4? For me, only in the case of exogenous T4, because again, there have been plenty of studies have showed that there is no, that there isn't a consistent therapeutic efficacy, equivalent therapeutic efficacy between levothyroxine and Synthroid brand. So for me, I'm really just adamant about Synthroid, the brand, and it could be Levoxyl too, but I usually just use Synthroid. I do. I'm sorry. The next question is, do you? Oops. How do I go back to the other question? Oh, you're welcome. The other question was, do I routinely use a TSH and free T4 in monitoring my patients that are already known to be hypothyroid? Actually, I do, and most of the guidelines suggest that you really only need to check a TSH, but I think because I'm an endocrinologist, I just usually check a T4 and a TSH. Are there any other questions? Okay, so we'll go on to talk about hyperthyroidism. So as I said, I think I see about 1 million of these 3 million patients. No one told me that when I moved to Atlanta that I was going to see so much hyperthyroidism, and it's just really incredible. So there are a number of things that you have to consider when you have a patient that presents with abnormal thyroid function tests that are consistent with thyrotoxicosis. Graves' disease, of course, is the most common disorder that can lead to hyperthyroidism, but you also have toxic multinodular goiter. You have you can have an adenoma, toxic adenoma, thyroiditis, which is a condition that we will talk about later on tonight. As I mentioned, you also have drugs that can cause effects on the thyroid gland, amiodarone, radioiodine contrast. If someone is being overtreated with their thyroid hormone for hypothyroidism, this could lead to hyperthyroidism. Struma ovarii is a teratoma of the ovary that is predominantly thyroid tissue, and then you can also have a pituitary adenoma that produces TSH. So when you break down the pathophysiology of hyperthyroidism, you have some conditions that will just lead to autonomous hormone production, and that's predominantly your adenomas, the multinodular adenomas, and the single adenomas. You also have leakage of the thyroid hormone from the gland. This would be Hashimoto's, lymphocytic infiltration. Medications can cause leakage of hormone from the gland, and subacute thyroiditis. And then you also have stimulation issues. So we'll talk about Graves' disease in more detail, but this is where you have increased glandular stimulation, and certain medications can also cause increased glandular stimulation. And then you could also have pituitary stimulation. And then I already talked about the struma ovarii, metastatic thyroid cancer, again, where you would have thyroid tissue outside of the thyroid gland. So again, Graves' disease is actually the most common cause for hyperthyroidism, and affects about so it's about 60 to 80% of all the causes of hyperthyroidism. So the interesting thing about this condition is that you have these antibodies that actually stimulate the thyrotropin, or the TSH receptor. And again, if you'll recall back to that cartoon that I showed you of the thyroid follicular cell, that's again where you'll have an antibody that's actually stimulating that receptor, stimulating the production of the thyroid hormones. And so there's no one single gene that has been associated with this condition. Always more common in females, just like hypothyroidism is more common in females. And then the highest risk of onset is between 40 to 60 years of age. Now, you know, the NHANES data basically has shown that that hyperthyroidism in Graves' disease is more common among whites and Asians. But again, being in Atlanta at Grady Memorial Hospital, you know, the majority of the patients that I see are actually African American patients, and I mean, I see so much hyperthyroidism among African American patients that I think that the data, they just didn't survey the right people. But you have to remember that Graves' disease is associated with other complications that are outside of the thyroid gland, and that is actually Graves' eye disease and dermopathy. So in addition to the stimulating antibodies that I already mentioned, you also can still get the elevated thyroid gland antibodies. So you can still have the anti-TPO and the anti-thyroglobulin antibodies, and these concentrations vary among patients, but I did mention before, but the thyroid stimulating immunoglobulins are very specific to Graves' disease, and so over 90% of the patients that have Graves' disease do have these thyroid stimulating immunoglobulins. But at the same time, patients with Graves' disease may also have antibodies that block the receptor, so it can be a very confusing picture at times, especially if a patient would go between having hypothyroidism and hyperthyroidism. I'm going to go ahead and I'll talk about this later, but also a lot of patients that once you treat them, they can actually go into remission with therapy, and that's because some of the medications actually have some immunomodulating effects. I'm actually going to stop. So Dr. Elliot Gonzalez has a question. Says, when the TSH is greater than 5, do you also check thyroglobulin antibody in addition to TPO antibodies? Yes, I do. And so at our lab, generally we just have a thyroid antibody panel, and that includes both the thyroglobulin antibody and the TPO antibody. You know, it's interesting, one of my colleagues that I train with, she for some reason doesn't really like checking antibodies. I think more recently she has started checking them, but for some reason she was very against checking antibodies. But again, for me, I think it really helps me kind of you know, educate the patient about, you know, their risk, and keeping them informed about you know, close monitoring for a potential overt hypothyroidism. Thank you for the question. So as again I mentioned, you know, there's these so there's actually two assays that check the same thing. So some labs will have what they call TRAB antibodies, and then some labs will actually have the thyroid stimulating immunoglobulins, and essentially they test the same thing, which are the antibodies to the receptor, but they're different lab assays, so they're performed in a different way. So hopefully that won't confuse you if you ever need to check them in the future. But like for example, the lab at Grady Hospital, we actually do TSI, and it's actually not run at our lab. We actually send it out through Quest, but that is the send out test that we use. But understand that the production of these antibodies don't necessarily correlate with the severity of the thyroid hormone production, and when this process does happen, you actually do have production of these antibodies within and outside of the thyroid gland. And so again, once these antibodies are stimulated, you actually have this really interesting immune cascade, which leads to cytokine production and inflammatory invasion of the thyroid gland. And again, this leads to this whole inflammation and this whole process of stimulating the gland. And so over time, this is why some people will actually present with an enlarged gland and a goiter, because of this inflammatory process that's actually taking place inside the thyroid gland related to these stimulatory antibodies. So I'm not sure if any of you have had the opportunity to see someone with Graves' eye disease. And it's pretty impressive when you see it, especially if they look like this picture. And so they get this, this severe chemosis, just like you've seen patients that are intubated, and they have all of the edema around the sclera. The lid is retracted, and some patients can't completely close their eyes when they try to go to sleep. So this corneal exposure would then lead to additional scarring and irritation of the cornea. If it's really severe, then patients may even not be able to move, to have normal extraocular motion. And so the CT scan down on the bottom, if you appreciate that, you can see inflammation and edema of the extraocular muscles around in the orbit there. So again, this is severe Graves' eye disease. So one of the things that's important to know is that if a patient is smoking, this does increase the risk of Graves' eye disease, and it can make it worse. In addition to that, men have more severe cases of Graves' eye disease. So this is just a cartoon that kind of, again, tells you what's happening with some of the inflammatory process. So again, you have inflammatory cells and these glycosaminoglycans that are actually invading the muscles, the eye muscles, and you also have these fibroblasts that are also in there, and this leads to that significant edema that you saw on the CT scan of the extraocular muscles. Again, in severe cases, you may also see skin disease, may not be able to fully appreciate the problems there on the skin of the legs, but it's kind of like a very faint erythematous rash. And then patients can also present with clubbing of their fingers and some bone changes that they describe as periosteal bone formation and proliferation that you can see there, and some soft tissue swelling. So the other reason why I find thyroid disease so interesting is just that there is this spectrum of autoimmune thyroid disease, whereas some patients, don't necessarily fit the classic course. So
While we're waiting, if anyone has any questions, then feel free to go ahead and submit them at this time. Thank you.
I apologize again. So again, you can have just very interesting courses for some patients. For example, a colleague emailed the other day about a question about a patient that she had, again, had a positive TSI, but at one point was hypothyroid, and now is and even had to be placed on Synthroid therapy. And then as time went on, for some reason she noticed that she had to use less and less Synthroid, only to completely withdraw the patient from Synthroid therapy, and the patient was now with a suppressed TSH and was looking hyperthyroid again. So as you can see, there's just a spectrum of autoimmune thyroid disease, and some of them can be pretty funky. So the symptoms, of course, of hyperthyroidism, as you'll see patients that are hyperactive and irritable and complain of heat intolerance and sweating, and they've lost weight despite having a pretty good appetite and haven't changed any of their activity. And I've seen patients present with hives. But one of the patients that I'll never forget was a young female who I think she had 2 kids, and she developed hyperthyroidism. And I was trying to explain to her different options for therapy, and I just remember the whole time that I was talking to her, she was just crying and boo-hooing and she was just she was just like all over the place. Like, she could not pay attention to anything that I was saying, and all she could do was cry, like I had just given her a diagnosis of cancer. But so that emotional lability I will never forget. And so if you ever see a patient like that, that will also make you never forget that particular symptom of hyperthyroidism. And oftentimes patients will say that they have, increased stool frequency, thirst, and polyuria. So then I thought I would also then just describe some of the changes that can happen in the cardiovascular system with hyperthyroidism. So opposite to hypothyroidism, you actually have decreased systemic vascular resistance. So again, someone who presents with severe thyrotoxicosis actually may be hypotensive, and they will be tachycardic, and they actually have this high output failure. So they have the increased ejection fraction and increased cardiac output, again related to their tachycardia. They also will have decreased isovolumetric relaxation time and increase in their blood volume. So what are the findings for hyperthyroidism? Well, again, you have a low or suppressed TSH. You're going to have your elevated T4 and T3. And this is the case where you actually do check a T3, because in some cases, like Graves' disease, and I think I mentioned this on an earlier slide, the gland in the cases of Graves' disease will actually preferentially produce T3. And as I told you from the beginning, that the gland usually puts out more T4 than T3, and then peripherally you convert T4 to T3. But in the cases of Graves' thyrotoxicosis, and often most cases, you'll see that there is a preferential production of T3. And as I mentioned earlier, if you have the opportunity to check a TSI, so I found that a lot of patients that come into Grady actually for admission are coming in for a severe hyperthyroidism, so they're getting admitted to the hospital for hyperthyroidism because they're so symptomatic. But at the same time, when you're trying to make a decision about what is the actual etiology of their hyperthyroidism, in that case, sending the TSI is not helpful, because as I mentioned earlier, it's a send-out test, and so it's going to take me at least a week to get the test back. So I have to make the decision of what I think their hyperthyroidism is related to, based on their history and some other factors. So I also, again, in this case, will check thyroid globulin and check thyroid peroxidase antibodies in someone with hyperthyroidism as well, because again, I can get these back in the same day, but I can't get back the TSI. Some other findings that go along with hyperthyroidism are hypercalcemia. You can get anemia. You can get elevated transaminases in severe cases as well, and you can also get lymphocytosis. We also recently had a very severe hyperthyroid patient that presented with pancytopenia, in addition to heart failure, as well as cholestatic jaundice. All right, so I'm going to pause here for another question. So I have recently heard and read about age-related norms regarding thyroid labs. What are your thoughts about this? So, actually, when it comes to treating when it comes to treating hypothyroidism, actually, there is some data to show that for older people, you actually do want to target a TSH around the upper limit of normal. So some would suggest that you maybe want to target around 4 to 5 for elderly people, and that's again related to the fact that their cardiovascular system may be a little more sensitive to thyroid hormone, and that targeting a lower end TSH may subject them to potentially being at risk for cardiovascular arrhythmias. And there was another question, but I can't see it. Do I need to scroll down?
Can you hear me?
Yes. Okay.
It says, how much do the antibody tests cost, and are they covered by insurance well?
I've not had any tests declined by insurance, but to actually tell you how much they cost, I apologize, I don't know. At our clinic, we do have a fee schedule for patients that are self-pay, and unfortunately we don't include the antibody test on there. So my suspicion is that it's too expensive to offer it at a discounted price, but I honestly don't know the exact cost for the antibody test. And like I said, I've never had anyone tell me that the insurance didn't pay for it. I think that was a blank slide. Okay, so this is just an example of a radioactive iodine. You know what? I think was the previous slide. Did it just take a minute for it to come up? Okay. So in the upper left-hand corner, you see that there is the normal uptake and scan for thyroid, and then if you look on the the upper right, you'll see that the Graves' disease, where you just see this diffuse increased uptake of the radioactive iodine, and that's consistent with we call this a homogeneous uptake, or homogeneous uptake. And so down below in C, you'll see the toxic multinodular goiter. So you see several small or large areas of increase, or the dark uptake areas. And then on picture D, you'll see that there's just one large area of the increased dark uptake, and that would be consistent with the toxic adenoma. So just, for purposes of this talk, understand that, there's two different types of radioactive iodine that's used. So there's the I-123, which is used for doing the radioactive iodine uptake and scan, and that is used for, because it had a shorter half-life, and it doesn't emit the same amount of the beta particles. But if you're doing therapy is actually with the I-131. So first we'll talk about drug therapy for treating hyperthyroidism. And I find that, because I do counsel patients a lot about their options for treatment, it's actually kind of difficult, because all of the options don't really seem that attractive. And so the medicines for treating hyperthyroidism are called thionamides, and there are two drugs. That's methimazole and there's PTU. So they're both in the same class, and they both basically work by preventing the thyroid peroxidase enzyme, and this then prevents the iodination of the tyrosine residues, and this prevents the synthesis of the thyroid hormones. But the nice thing about these drugs is that they actually have some modulatory effects, and they actually can reduce the inflammatory process in this inflammatory cascade that I kind of talked about earlier. And so over time with these medicines, you actually can see a decrease in these antibodies. And so for methimazole in particular, it can be given in a dose of 5 to 60 milligrams a day, and this can be given in divided doses, or it can be given all at one time. Initially, if someone's really severely hyperthyroid, I like to give it at least twice a day, and then as they start to become more euthyroid, then I will give it to them once a day. The important thing to know about methimazole is, and particularly because we have so many women who are actually presenting with hyperthyroidism, is that if they are of childbearing age, that you do want to consider that this is a pregnancy category D. But then again, if a woman gets pregnant and then develops a diagnosis of hyperthyroidism, you need to understand which medicines are used. And methimazole is actually, it can be used in pregnancy, but it's recommended to not begin the treatment with methimazole before the second trimester. And this is because there have been cases of the condition aplasia cutis. And so this, again, it happens in the first trimester, and so typically we don't use methimazole in the first trimester. However, I am told that in other Eastern countries, methimazole and actually its metabolite carbimazole are actually used quite regularly and are used all the time in pregnancy. And so I don't know their rates of the aplasia cutis, but it doesn't seem like this is it's very common. It's still a rare side effect, a potential side effect of this medication. And the nice thing is that the transplacental passage alone. So if a woman again decides that she wants to nurse after she delivers the baby, the milk level, breast milk level is low of the methimazole. So as I mentioned earlier, I have here circled in the orange area, you can see where the action of the thionamides is at this process right here, where the thyroid peroxidase enhances this interaction here of the iodine with the thyroglobulin and the tyrosine residues. So the other thionamide that is the oldest thionamide is PTU. And more recently, PTU has really fallen out of favor as the drug of choice for treatment of hyperthyroidism because of its association with hepatotoxicity, which I'll talk about a little bit later. But essentially, it does the same thing, but additionally, PTU has been shown to be able to block the peripheral conversion of T4 to T3. However, this is usually not very clinically significant. And I remember when I was in residency that it was always like, oh, PTU, PTU, because PTU, in addition to blocking thyroid hormone production, can block the peripheral conversion. And so it was, always the preferred drug. But again, as it's become more associated with hepatotoxicity, it's kind of fallen out of favor. And really, at this point, the drug of choice is methimazole. So, as I mentioned before about pregnancy, because we can't use, or it's not recommended to use methimazole in the first trimester pregnancy, but PTU is what we have to use in the first trimester pregnancy. And so in some cases, if I haven't had any women recently that have presented to me in the first trimester, but in that case, if they did, I would put them on PTU, and then when they transition to their second trimester, I would change them over to methimazole. Most of the women that I've seen, pregnant women I've seen lately, have actually already been in their second trimester. And same thing, PTU though, how it has to be given in divided doses, so it has to be given 3 times a day, which is, I think 3 times a day dosing is pretty inconvenient, and most people always forget one of those doses. So, and this, of course, if they forget a dose, that could also impair the ability to get the hyperthyroidism under control. So when you look at the side effect profiles of the drugs, they look very similar And the agranulocytosis is a big deal with the methimazole, and I'll talk a little bit about that later. But you can also see that with PTU. You can see more of a cholestatic picture with methimazole as opposed to a hepatotoxicity that you see with PTU. PTU also additionally has potential for vasculitis, and both of them, as you can see, are associated with a rash and urticaria. Oops, sorry about that. And so with methimazole, you do have to tell people that there is a potential for this agranulocytosis. However, at the same time, it's not recommended that you do routine CBC screening. And so I tell the patients that, because it is associated with this agranulocytosis, that in the event that you develop an upper respiratory infection, that you have to stop the medicine, and then you have to contact me immediately so that I could send you to the lab and we can check your white blood cell count. Obviously, if it's okay, then they can resume the medicine, and their upper respiratory infection will have its self-limiting course. However, if you do find that there is a change in their white blood cell count and that their granulocyte count is less than 1,000, then you do need to discontinue the drug and find another treatment option. And so, as I mentioned, with PTU, again, it's kind of fallen out of favor for first-line treatment because of this hepatotoxicity. And so anywhere from 30% of patients will actually develop abnormal LFTs while they're on PTU, and that could be anywhere from 1 to 6 times the upper limit of normal. For the most part, this usually takes place within the first 3 months of therapy, but it has a pretty high fatality rate, and you even have patients that may need liver transplantation related to hepatotoxicity associated with PTU. So, but the interesting thing is that routine screening with LFTs is not recommended. So clearly I talk too slow, and so I'm going to go ahead and wrap this up. So with the anti-thyroid drugs, you actually should check TFTs every 4 to 6 weeks until the patient is euthyroid. If you need to treat someone for the symptoms of hyperthyroidism, you also can add a beta blocker, and this would be to get their heart rate down to less than 100 beats per minute.
Is it stuck?
Oh no.
You're done?
No.
Okay.
Okay. Oh, sorry. Okay. So radioactive iodine is the next option for treatment, and radioactive iodine is a good option for a lot of patients because it's basically definitive treatment, and so in the way that the normal thyroid cell takes up iodine, it takes up the radioactive iodine, but then the radioactive iodine releases these beta particles, which causes death of the thyroid cells, and this will treat the overstimulation or the autonomy of the thyroid gland. And so the nice thing about it is that patients will begin to see improvement in their thyroid function in about 6 to 8 weeks, but the full benefit is usually seen in about 3 months. So the nice thing too is that with the radioactive iodine therapy, patients can actually see a decrease in the size of their thyroid gland. And of course, the downside is that there is a relationship between the radioactive iodine therapy and hypothyroidism, which of course is the biggest side effect. And so in the first year, there is a correlation between the dose of radioactive iodine and hypothyroidism, but after that there's about a 2 to 3% per year risk of hypothyroidism. And I will say that treatment for Graves' disease is actually a higher risk for is a higher risk for becoming hypothyroid after radioactive iodine therapy, and it's less of that risk when you have multinodular goiters. This is just showing you again that the radioactive iodine would enter into the cell the same way through this sodium iodine symporter. Biggest side effect, in addition to the hypothyroidism, that sometimes people can have inflammation of their salivary gland and may have some mild nausea. People have to understand that you are emitting radioactive iodine particles, so that you can't have prolonged close contact with people for at least 5 days after therapy. And so you can't share utensils, and these are things that you have to educate the patient about. Usually check TFTs about 6 weeks after therapy, looking for their thyroid hormone levels to come down. In some cases, patients may still be hyperthyroid, and this may be because they didn't receive enough radioactive iodine therapy, or because it just hasn't onset, the action hasn't onset yet. But in some cases, radioactive iodine treatment itself can cause release of the preformed thyroid hormone, and this can also lead to hyperthyroidism after treatment. Surgery obviously is not a first-line treatment for this, and so there are some cases where you may consider therapy in pregnant patients or patients who obviously are not who are not candidates for the other 2 therapies. So I'll just briefly go through thyroiditis, and things to remember is that there's 2 sets. There's an autoimmune and then there's a non-autoimmune. We've already talked about Hashimoto's, and we've talked about some drug-induced thyroiditis, but in between you also have painless sporadic thyroiditis, and you also have infectious or suppurative thyroiditis along with this. And I think the key things about thyroiditis is that you know, with the autoimmune ones, you will see elevated TPO and thyroglobulin antibodies. But the thing to remember is that this differs from Graves' disease and toxic multinodular goiter or toxic adenoma, in such that the radioactive iodine uptake is actually very low. So it's going to be less than about 5%, whereas with Graves' disease and toxic multinodular goiter, you're going to see uptakes that are higher than the upper limit of normal, which the normal in most scans is about 35%. So at 24 hours, you're going to see for Graves and toxic multinodular goiters, you're going to see about greater than 35% for hypothyroidism. And you can see postpartum thyroiditis, which obviously happens after a woman delivers a child. It can be anywhere between 1 to 6 months after delivery. And painful subacute thyroiditis, again, is more common in women, but you also can see hyper and hypothyroidism with thyroiditis, and these people actually have a high ESR. And then for the most part, for patients, you just, if in the hyperthyroid phase, the important thing to know is that because this is not related to a glandular stimulation, the hyperthyroid phase of thyroiditis is related to release of the preformed hormone. So you're not actually producing more hormone. So you actually don't want to treat them with anti-thyroid hormones. You actually just treat the symptoms, which if they need the beta blocker for the tachycardia, you would give them a beta blocker. If they go into a hypothyroid phase, and then you would just treat them with levothyroxine if they need it, if the symptoms are severe enough. And this is a slide for you to remember that in the early phase of thyroiditis, you'll see hyperthyroidism. So you'll have elevated T4 and T3 with a low TSH. As time goes on, and as all of the preformed hormone is released, then you go into a hypothyroid phase, and then over time you recover. And this can actually go anywhere from 1 month to 12 months for this course to walk through. And we'll pass through this. So again, suppurative thyroiditis is when you actually have a bacterial infection, and the way to treat this is that you have to drain the infection. So amiodarone is a drug that commonly is associated with thyroiditis. It can cause hyperthyroidism, and there are 2 types of hyperthyroidism. One is related to excess iodine, and the other one is related to a destructive inflammatory process. And so they have 2 different treatments. So the excess iodine you do treat with anti-thyroid drugs, and with the destructive inflammatory type, you would have to treat with corticosteroids. And there also would be a difference in the radioactive iodine uptake. So with the type 1, you would see increased uptake, and with type 2, you would see a decreased uptake on the radioactive iodine study. And then you obviously want to look at their baseline thyroid function before starting amnio.
Hello everyone, we apologize again for the technical difficulties. This would be a good time for us to do our closing. I would like to say if any of you would like to have a copy of the slide, we were behind due to the connection issues. So if any of you would like to have a copy of the slides, then please feel free to email me, Sabrina Jackson, at sajackson@msm.edu. Or if you go to the website, then you can email at the admin queue. But again, I am sajackson@msm for Morehouse School of Medicine.edu. So I'd like to thank Dr. Lowry for this insightful and engaging presentation tonight on thyroid disease. I'd like to thank you, the audience, for your participation, for your questions and your comments, and also for sticking with us with all of these technical difficulties. Again, these webinar series are made possible to you through a partnership between the National Health Service Corps, Morehouse School of Medicine, and Clinical Directors Network. We would also like to bring your attention to the upcoming events that we have. On next Tuesday, April 17th, you're invited to attend a coffee shop, and we will be discussing updates and controversies in family planning. On Wednesday of next week, there is another CE-approved webinar on HIV in the correctional setting. And on next Thursday, there's going to be a coffee shop on the following Tuesday, there will be a coffee shop on the maternal child health coffee shop on emergency contraception. So thank you again also to our technical person, Qualin, here tonight. Thank you, Dr. Lowry. Direct financial support for this webinar is made possible through a cooperative agreement with HHS, HRSA, and the Bureau of Clinician and Recruitment Services. Please take a few moments to fill out your evaluation that should be popping up, and that will allow you to obtain your CE credit. Again, if you'd like to have a copy of the slides, then please email me at sajackson@msm.edu. Thank you very, very much, and have an awesome evening.
Thank you.